Thank you. Pleasure to be here and delighted to be with you this evening. I have the pleasure of moderating a panel of experts coming from multiple views, I think, of the COVID epidemic. I think we've all been sort of bombarded with the question of COVID, and the focus of the panel tonight is really focusing on vaccine distribution, which is the stage we're all at, and I think anxious about and watching carefully. And we're very fortunate to have individuals from who's going to be talking about the global situation. We have a national figure in a national health agency, and we have an individual from NYU and with student services, as well as experience in community health centers. And we hope we have a community practitioner who probably is seeing a patient and it's a little bit late tonight. So welcome. Let me give you an introduction to the panelists, and we'll be having a discussion, sort of Q&A, as Elise said, and then we'll manage it among ourselves until we open it to you. So the first panelist I want to just speak to, starting from the global area, Professor Michael Merson, who is the Joklik Professor of Global Health and Professor of Medicine at Duke University. He's also a visiting faculty here at the School of Global Public Health and valued colleague. He's a founding director of the Duke Global Health Institute and has extensive global experience leading the AIDS program at WHO prior to the establishment of UNAIDS, and then being a consultant on, I think, every entity that focuses on infectious disease, HIV, and other pandemics over the last 25 years. So we're very fortunate to have him here with us tonight to provide a global perspective to our focus. The second individual is Dr. Kameron Matthews, who's Assistant Undersecretary for Health for Clinical Services and Chief Medical Officer of the Veterans Health Administration, which is our closest model towards, I suppose, socialized medicine, institutionalized medicine, where our population is guaranteed care. And she's going to reflect on the impact of the COVID, especially the vaccine distribution issues and other issues on the VA system. And Dr. Anna Saporito, who is a family physician, who is at the NYU Student Health Center. As she pointed out in our pre-conversation, she hasn't had vaccine to distribute yet, but I'm sure she's eager to manage it. She can tell us about that. And she's also has professional experience in a community health center area, which she'll share with us as well. And then finally, Dr. Alexander Salerno was to have been and may still be our fourth panelist, and he is in family-owned practice, medical associates practice, serving East Orange and the Newark communities, and has been a founder of the Urban Healthcare Initiative Program, which is a nonprofit focusing on quality healthcare education to urban communities in New Jersey, to provide his experience with his community if he's able to join us. So I'm going to start with the first question and ask colleagues to respond in the order that I introduced them. Mike first, and then Kameron, if I may use your first names, and then Anna. What has your experience been with the vaccine rollout, and especially with regards to distribution and administration to patients, to communities, in your case, Michael, to countries that you are concerned about professionally? What have been what have been the realities you've been facing in your own institution, and then some of the challenges and opportunities? And then we'll do a deeper dive into the specifics of that in some subsequent questioning. So Mike, you want to start? Unmute yourself.
Hi, nice to be with you. I think just to put this in perspective, we've never in our history had to roll out a vaccine to 8 billion persons in every country of the world in a relatively short period of time. So the challenges have been substantial. Current model, if we don't improve what we're doing, we won't get first vaccinations into the entire world before 2023 or 2024. So we've got a challenge ahead of us. I'll briefly tell you what's happening. The WHO Gavi, which is a vaccine group, and CEPI, which is a vaccine research group. They set up a facility called COVAX about 8 months ago, and its goal was to obtain and distribute vaccine equally to all low and middle income countries. And their initial goal was to have 2 billion doses by the end of 2021, which would protect high risk and vulnerable people as well as frontline health workers, about 20% of the population in low and middle income countries. And it depends on whether 1 or 2 doses. But let's just keep that 2 billion doses in mind. But that's only 20% of the population. And that was a not unreasonable goal. But then what happened, and what has happened, is many of the wealthy countries have bought up a great deal of our supply. Just to give you some numbers, of course, in the US, we have an Operation Warp Speed, but there are many developed countries have their own version of Operation Warp Speed. But just to give you some numbers, the richer countries have purchased already 8.3 billion doses, and they have another 6.4 on hold. That's 14.7 billion doses already locked in. And for the US and the European Union, Canada, and the UK, that amount is far more than we're likely to need. So clearly there's a challenge for the low and middle income countries. Some of the middle income countries like India and Brazil, they've been able to purchase, but also to produce. They've got the capabilities. A few countries like Peru have been able to get vaccines because they've been involved in clinical trials. But for the most part, we've got our real challenges ahead at a global level. And Joe, just to mention 1 or 2 other things very briefly, certainly if you think of low and middle income countries, you have issues around cost of vaccines. The prices are varying from $6 to $74 for the same vaccine per dose. And of course, the whole question of delivery. Most of the immunization programs in low and middle income countries are for children, giving the childhood vaccines. And we are trying here to vaccinate all ages, and children right now are not even a priority. So getting the cold chain, getting the delivery systems, you need some cold chain, particularly for the mRNA vaccines. This has also been a great challenge. So we got a lot ahead of us, and we're going to need to step up.
Okay, thanks, Mike. Well, we'll come back to some specifics a little bit later. Dr. Matthews, from the VA, from the national perspective, you're probably closer to some of the decision making in this country. You let us know how you see it.
Yeah, I think, thanks for the question. I think operationally, this has been, sorry, my dog just chooses now to go crazy. This has really been, a challenge, particularly as we're, as an integrated health system, really needing to make decisions so that we could cross-level supply as much as possible. So pretty early on, the decisions, like Mike mentioned, about freezers and just assuring that we had the appropriate capacity to hold the supply was a pretty massive lift, because the entire country was having those conversations. So just the orders and the ridiculous prices that started coming across for freezers and fridges to store these, besides the fact that the pizza boxes that at least, the actual containers that the vaccines came in were 100 doses for one of the mRNA, but 1,000 doses in the other. So you needed to absolutely plan, where would you actually have the population so that you could use 1,000 doses. And some of our smaller rural clinics were not in any way reaching that number of population. So there was a lot of logistics involved on where we actually had to put them, where they could travel to, because initially the CDC and Pfizer and Moderna were having restrictions on the length of time they could travel, not just how long it needed to actually defrost, but how long they could actually travel. So our ability to move the products around was something also that we had to map on a national scale. I think overall, the reason why we've been successful, we've vaccinated now more than 1.5 million veterans nationwide. We're also vaccinating their caregivers as well if they're part of our formal comprehensive assistance program. One of the reasons why we're successful is because we have a known patient population. We know who they are. We are actually reaching out to them. The expectation is that they are not reaching to us initially to get their appointment. We're actually reaching out to them. And we do it through actually our typical outreach methods in terms of we're following the data, we're following our registries of veterans. And so we just basically sorted it by CDC guidance and risk stratification. So we knew exactly which veterans to call to get in those in at least the first priority class. And then of course, our essential workers, of which we've done as well too. The other piece we're pretty proud of is we're also vaccinating other federal employees. So we're doing Homeland Security. We're doing the historical archives, which is a funny, interesting one. They're based out of St. Louis because the archives are where a lot of the medical records for veterans are stored. And so we need to be able to get the archives moving so that we can get more veterans enrolled, because over the past year, there's been difficulty and just a little bit of a logjam of getting veterans examined and registered into the system. So it's interesting what we're doing, but I actually would deem it probably one of the more successful efforts because we are able to make those difficult logistic decisions, but we're able to cross level while doing so.
Yeah, no, that's really helpful. I think a lot of countries that have more integrated health systems than ours have been shown to be more successful, especially on the vaccine, distribution and rollout issues. Dr. Saporito, you're maybe you could be a little bit aspirational about how would you see it when the health service has it, or tell us about community health center experience.
I see David Freed is here, and he probably has I'm putting him on the spot. He doesn't even have his camera on, but I think he probably knows more. But I know that NYU Student Health Center is absolutely 100% ready the moment we get the shipments. They just haven't happened. So I've been trying to get my vulnerable patients access to vaccines through the state and the city programs. And that's been remarkably good for NYU students are incredibly savvy, and they've been getting appointments, which is amazing because I can't find them for my the building cleaning staff, things like that. We've been working with a friend who's a computer hacker to figure out the cancellations of the Javits Center state site and go on at midnight. New Jersey, I'd be so interested to hear how a New Jersey provider is doing, because New Jersey is almost impossible to navigate if you are an elderly at-risk person and trying to get a vaccine. I'm so jealous of the VA system, and I hope that these sorts of things, having worked at a federally qualified community health center for the last decade and a half, we should have a better system than we have. And we know what other countries are doing. It's not reinventing the wheel. We could just learn from this and move forward. That's my political statement of the night. It'd be amazing if we had better logistics. And this is really laying bare the disparities in healthcare and how difficult it is to get people appointments who don't already have a primary care doctor or a medical home and are therefore more at risk for complications from COVID.
Okay, no, that's great to get this off. And I want to let's talk about the access thing. Let me ask you maybe specifically, Dr. Matthews, you talk about, you have an identified population outreach, but the VA has maybe been historically, at least, a little more hospital based than ambulatory care based or outreach oriented. How has this changed your way of being relative to the access question? Because you flagged it, you see maybe you've overcome some problems.
It's a good point, but honestly, we have a pretty large outpatient infrastructure. In fact, the majority of our 1,200 facilities are actually outpatient based. About 170 of them are inpatient centers. But then, of course, we have our community living centers and our spinal cord injury residential homes and our mental health residential treatment centers. So we actually really attempted to, work with the CDC, of course, in helping them create their initial risk stratification, but from that immediately saved a portion of the vaccine supply that we were getting to cover our congregate settings. So community living centers, spinal cord injury patients, and then anyone currently, of course, essential workers working in either the ICU, regular med surg floors, or the EDs. And then we just went from there. So as much as the majority of, yes, the veterans that we need to reach from a risk stratification standpoint, yes, would be coming through outpatient, we actually judged that our congregate setting veterans were actually at highest risk. So went for them first. Then, of course, the outreach for 75-year-olds. So we've been doing mass vaccination events. We've been setting up tents and having drive ups and, just jamming them in the arm in the open window. We've been doing it in our outpatient clinics. And then actually we have mobile deployment vans. So for our rural areas, we actually even flew a case of vaccines to a VFW site in Montana, in rural Montana, where we actually don't have a clinic because we knew we had a good core of veterans there that wouldn't be able to get to the medical center, the inpatient. So we're purposefully targeting and really trying to make sure that we cross-level the supply away from our medical centers, but into the outpatient space so that we can ensure there's equitable access.
That's great. Thank you. That's really, really helpful. Mike, I wanted to extend this into the global conversation because I've been on some webinars lately in South Asia and colleagues in Africa who the countries have a pretty organized plan about how they want to proceed. And some of them have apparently secured vaccine or at least ordered vaccine. And you mentioned a couple of countries that are producing their own. Could you talk a little bit about the sort of access, this special access concerns generally? Obviously, the global mechanism that's trying to be as equitable as possible, but maybe specific examples of problems that low-income countries may be having.
You make a good point that a lot of the countries do have plans, and WHO's had a role in that. There is a roadmap, believe it or not, that countries are using, produced by something called SAGE, which is an advisory board in WHO, that takes into account in a good way, the status of the pandemic, how much supply they have, the particular vaccine, the population subgroups, et cetera. And so they have been able to come up with a plan. And I think that's a good thing. Of course, there are challenges. The rural populations lack health facilities. Poor populations don't have resources to get to a place where you can get a vaccine. There's been a lot of lockdown, which has discouraged people from coming. There's also a real reality, particularly in Africa, where in fact there hasn't been, and this is a whole nother topic, as much disease as we feared or as much death as we feared. There's been a great reluctance for people to go to their healthcare workers, like we saw in this country in the pandemic. And so a lot of other health services have suffered because people are putting off going even for routine vaccination, AIDS, drugs, family planning, et cetera. And so the challenges that COVID has presented have been substantial. There's also a real problem, which probably people don't talk much about in many Asian and African countries, of vaccine hesitancy. And there are a number of reasons for that, some of which are similar to what we see in this country, certain populations not trusting the government. If you think of Pakistan, for example, there's been a huge problem there, not trusting a Western vaccine for reasons that we know the history. In India, there's a lot of skepticism, believe it or not, about the vaccine made there. So I think that has also been a challenge. And then I would mention one other challenge, which we have in this country, which I term vaccine alarmism, which is, what do I mean by that? I mean, where we go around saying, well, it's not 100% effective and it doesn't completely prevent transmission and you can't change your behavior. And although these warnings have some truth in them, all told, they make a lot of doubt in people's mind about why bother to get vaccinated. And I think this is another issue. So some of the challenges, Joe, are like here. Some are special to the poorer countries.
No, I'm glad you introduced this issue of sort of vaccine hesitancy, because the idea of getting more people vaccinated obviously is, once assuming the supply is there. And Dr. Matthews, you were sort of nodding your head around. Maybe you could just address the issues, the hesitancy issues you might have seen or concerns about it. And then maybe Dr. Saporito, you said all the students are flocking to get the shots, but will help us understand what that's about. So maybe Dr. Matthews, you want to start with that one?
Yeah, we started off very early having the question about hesitancy. I was particularly interested in across the southern parts of the country where not only our veterans might have some hesitancy, but we had significant facility staff that were going to be turning away the vaccine. And we really needed to get an assessment of that. And so we were able to pull together some quick focus groups within the healthcare system to get an understanding of what their needs were, what their concerns were, how to address their questions, what type of really kind of visual cues and outreach we needed to be doing. And really the sum of it was that there's clearly no single answer, that, it needs to be really that individualized connection. So we really started using multiple different coordinators that we have in our facilities. We have minority veteran outreach coordinators that were part of the calling queue of calling the veterans and really answering their questions. We started bringing in community members and, faith leaders to have conversations. We were having town halls. We were purposefully writing editorials. We had many of our nurses, many of our staff. I wrote an editorial that went across the nation just to really try to address every point that was raised in a lot of the focus groups. And we really found actually that even though the marketing was a big thing, most of really the impact were those one-on-one conversations. We're hearing that time and time again. And such that, with our targeted outreach, with those conversations, with that really purposeful really outreach that we were doing, we're actually finding our data. We were all kind of shocked. We're actually vaccinating brown and Black veterans at higher rates than we are of our other veterans, just proportionately, because we've done that targeted outreach. So we're pretty proud of that. It's not really out in the public yet. And it's proportional, of course, just because of, the numbers. But we really are excited that, and, to show that this intervention, the targeted outreach is really meaningful and it does work.
That's fantastic and really, really important. Dr. Saporito, in terms of your reflections or what you're hearing about student uptake and enthusiasm, and if you were to have the vaccine, what would any concerns be around that question?
Yeah, I mean, it's different than my underserved communities that I'm working on on a volunteer basis. I totally agree. I've worked on vaccine hesitancy for years. And if you present people with facts, they tend to dig in their heels. And if you present people with stories and connections and have providers that look and talk like you and are able to identify with you personally, Dr. Matthews just put everything so succinctly of what is important in getting people to be vaccinated. NYU students are a different crowd, and they're global, and they're ready to move on with their lives. And because we've had such a great adherence to mask wearing and social distancing, and we've put on such strict restrictions for dorm life and school life, I think everyone is chomping at the bit to get vaccinated, and I can't wait to get it into everyone's arms. But I do think that there's a great need for people like public health ambassadors, peer educators, to get the vaccine and then to explain why they got it and to convince their classmates to join into the fun. It only takes one person to get vaccinated, and then they're going to get all of their friends and family vaccinated because they'll see that their family member was safe and is freer and less scared to function in the world after being vaccinated. And it's not as scary as it sounds, even though some of the side effects can be a little rough.
Yeah, no, that's really important. I guess to think a little bit about the broader policies and programs. I mean, just specifically, maybe starting with Dr. Matthews, you're in the leadership role in a national agency, and are there any existing sort of policies, programs that are undermining in some sense your ability to respond quickly, to have some of the successes or things that are working for you? I think that would be one thing. I mean, you could talk about national policy because you're closer to it as well, but have you seen a big change since the election in terms of openness, or were you all sort of cooking on all cylinders anyway?
We were pretty much cooking. And so really, I think the change with the administration is really lying with, honestly, supply chain, right? I mean, there, the president even announced that, all adults by May 1st today. I mean, there's, we're just waiting for supply, and we have the staff and the ability to vaccinate more and more. I think what is somewhat concerning for us and giving us a bit of hesitancy and why sometimes we're a little quiet on our successes is because the rest of the administration, the country is starting to turn to us perhaps to help in those areas where it might be a little difficult to host vaccination events, or because we have the logistics, we have the supply, we're the largest healthcare system in the country, and so we are helping in specific communities, but unfortunately, it only goes so far as those communities have their own supply. We are not being granted additional vaccine supply to help other communities. We're happy to do it, but at this point, we really obviously have to prioritize that our own supply lies with veterans. But I think it's the one thing that most don't recognize about the VA health system. It's actually part of our mission to help the larger public health infrastructure. It's literally written within our description. We, of course, treat veterans first. We have a research mission, we have a teaching and education mission, but the fourth mission is assisting with emergency management and larger public health emergencies. And so we've been proud to do that, and vaccines have been a big part of that. So we're helping with, we have state veteran homes in every state, multiple in every state. Those are not run by the VA, although everyone thinks they are. We have some slight oversight of them, but they're not our facilities. So we've been helping vaccinate them. So we're doing what we can. But I think it's not so much the policies and the programs that are the difficulty, it's the supply. We'd be ready and willing to step up if there was more product available.
What about family members? I wanted to ask her just one quick was what about family members of veterans? What's the policy there?
So right now we're doing caregivers. So we have a formal program in which caregivers are actually registered with the VA, and a lot of it has to do with the needs, basically the activities of daily living limitations and of the actual veteran. So if you are a recognized primary or secondary caregiver, we actually will vaccinate you now. That's a newer step, I think the last count I saw, oh gosh, somebody's gonna fire me. I think maybe it's not a large number of caregivers. It's less than 100,000. It's so we're managing that. There is a bill on the floor now of the Senate to cover all household family members of veterans. This is going to be massive. And we're, talking, of course, with the White House about, possibilities of how that's going to come about. There's also a potential that we may expand beyond just enrolled veterans. So for those of you that don't know, not all veterans can receive care in the VA system. You have to be eligible, which is usually based on either the era of the war that you served in or income. so not all veterans. We have about 21 million veterans in the country. Only about 9 million are enrolled with us, and only about 6 million use the system. Our supply has been based on that 6 million number. There is the latest bill, though, that is going to open it up to all veterans, regardless of eligibility of enrollment. So that's up to 21 million. Then if you add in the family members, we're looking at about 30 million that we'd be responsible for. So that's a bit scary. And we're looking at the logistics now about what that would take. But again, they can give us all the authority that they want. But again, if we don't have the supply, it's going to be a lot of disappointment, I think.
Yeah. Mike, what were you going to join in on the global side?
Cameron, I wanted to tell Cameron that I want to wind the clock now to maybe July or August, and the U.S. is sitting on an extra 300 million doses of vaccine that it can't use, and probably ought to help some countries out, maybe give it away like the Chinese have done, and the Russians and the Indians. And I remember what the military did so beautifully in the Ebola outbreak in West Africa. So I'm wondering if you're getting ready to help vaccinate, travel with these 300 million doses around the world as well, maybe in the fall, to help some poorer countries get vaccinated. How does that challenge sound?
So, we haven't started having those conversations. Most likely that would still rest with DOD, just because VA, we don't really end up doing a lot of work internationally. We would probably be seeking out the veterans that are enrolled in our foreign medical program, which is also a very small number. Small number, maybe about 30,000.
But DOD can do that?
Probably not the best person to answer that question, to be honest. I think they have the infrastructure, they have, the ability to travel. Whether or not they have the manpower to do those numbers is a completely different piece. So whether or not
I just have such faith in the military.
Yeah.
Well, let me put you on the spot though, because I think this sort of question about policies and programs. I mean, we've talked about, the issue of, you talked about, dominance of buyout of vaccine and sort of variability. Are there any, things that the global mechanisms, global governance structures, changes that you think could be made, or that you see have been made and we could have positive results, or things that need to be changed to get out of the way?
Well, I would say two quick things. One is that we had to invent COVAX on the spot. And I think we need to step back now and say, okay, it'll help, but it's not going to solve it. And I think it's time soon to look at COVAX and see whether we need another better global governance structure, Joe, to do what needs to be done, either for this pandemic or the next pandemic. And then secondly, the issue of supply is a huge one. As probably some of you know, there's been a huge debate in the World Trade Organization about whether the vaccines should come off patent. There should be a waiver of the patents so that any country could produce the vaccines. Not surprisingly, pharma is fighting against this. They feel they've invested a great deal in research. They feel that you were going to need them for the mutant vaccines. But I do think we need to think about a tech transfer mechanism and some other kind of global mechanisms, Joe, to be able to get these vaccines manufactured in many more countries. The technologies are, some of them, like the mRNA, is advanced, but not that advanced, that many countries couldn't do it. So if you ask me to pick two things, those would be the two things that at a global level, I hope we would look at. And I'm confident, maybe that's the right word, that the current administration will be much more interested in solving this than the previous administration.
Dr. Saporito, you get maybe just this last word on if you were able to change policies or programs. We've obviously talked about access to the vaccine here, but maybe from the community health center point of view or the university point of view.
Right. I mean, of course, it shouldn't be patented. The polio vaccine wasn't. Yeah, I agree. Seconded.
Anything else?
I mean, we need to, with the supply too, I think there's a huge issue right now with these mass vaccination sites targeting actual communities that need it. And I think that's been in the news a lot, or maybe not enough, but if we could follow the model of maybe the Indian Health Service, I think they did an amazing job, and I think the VA did an amazing job at getting vaccine supplies to the actual community health centers that treat their own patients and could outreach exactly the way the VA did it. Right now, we're not seeing a huge shipments going to federally qualified community health centers and there's a reason why the Indian Health Service has been incredibly successful at doing this.
Yeah.
And we're failing at other places. My patients the main Queen site is not very accessible to Corona or to Elmhurst by public transit. It's about an hour Uber ride to get people from the highest hit area of COVID to the mass vaccination site in Queens. Who's it?
If I could add to that, you're exactly right, Anna. I was only at FQHCs before I came to the VA, so I was practiced in Chicago before I came to the VA. And Joe, your question earlier about VA's system being so inpatient based, that's exactly how the distribution has been based, that they've been shipping it to academic medical centers and larger hospitals as opposed to FQHCs. It's completely revealing the lack of a public health infrastructure in most states. I mean, even when California needs to turn to Kaiser and United to distribute their vaccine, that means there's absolutely no infrastructure to get into some of those communities. I think this is just revealing, just as much as the, kind of racial and ethnic disparities about access to acute care services as earlier in the pandemic we saw. I think this is revealing some significant infrastructure weakness points that need to be addressed before we're faced with the next public health emergency.
Yeah. No, I think it's an important point, and that just announced in the city that FQHCs and pharmacies now will be integrated effectively. But I think statewide, I'm on the state public health council, and one of the observations made very early was really a failure to mobilize community health centers and local health departments at the county level that could have been much more helpful in a sort of integrated approach. And obviously going forward with vaccine distribution, hopefully are sort of included more now. But I think the press dominance, it's the same for pre-COVID, is the hospitals tend to be the dominant voice, I think, very often in health policy. So we've learned a good lesson here for the need for more integration with public health, local health departments, and with primary care. So that's great. I think I'm getting signals from my colleagues here that we're ready to move into the open segment. So I want to thank you for a great discussion and more questions coming, I think. Elise, are you fielding these?